Now, at 8:03, family, my guest, the clinical director, we have two clinical directors from BHB. We have the clinical director of Med-Surg, Norma Smith, and nurse Norma Smith, and we have the clinical director of critical care services, nurse Lynnette Bean. And no, it's not Nurses Month, we finished that yesterday, but we have BHB here, because we moved into an acute care wing. How long ago was that again, ladies?
Almost 2 years.
Almost 2 years.
September 2014.
Wow, and you guys haven't been here since June last year. So it's like, oh my gosh, it's June again. Yes. So, yes, there we go. So, therefore, let's tell us what's been going on at BHB since the move, since you were last here.
Well, Beverly, I think my colleague would agree. It feels like home. We're working, and other issues, of course, but by and large, it is a beautiful new building. And more importantly than that, patients have the space, the privacy, and the services that have been purpose-built for what they need, i.e. we didn't renovate. We moved in new, had the opportunity to put everything where everything needs to be the most efficient for our staff and our patients. So we're in, and it feels like home.
Yes. Now, family, if you have any questions for the clinical directors, then give us a call at 297-1027, because we want to hear from you. They're going to be sharing in a few minutes how you can help us so that we can help you. But if you have questions, then feel free to give us a call at 297-1027. Okay, now, what's the... I guess, yeah, you're right. I think it is a beautiful, beautiful, beautiful building. And, yeah, I think you're right. We are at home. Like, I'm no longer lost. I'm no longer getting 42,000 steps in a shift. I'm down to, 20. I'm just saying. Anyway, but so, in terms of, you said that we have a few little issues. But I think, I think we give exceptional care every day.
Every day.
And, I really think that we do, but we're not perfect, and nobody is perfect, I'm just saying. But, so what are some of the issues? How can the public help us? What is it they could do? Because, one of the things we often hear, people complain about how long when they come to the emergency department, how long they have to wait. So maybe you could explain a little bit about what triage is, how that process works, and quote unquote, why there is a long wait. Because a person's perception is their reality, even though it may not be the reality.
Okay, well, for the emergency room, yes, we are working through some glitches, but on the whole, we are providing that exceptional care. And yes, there is a wait. And as you said, everybody's wait, their perception is their reality. But we triage and we try to categorize people based on...
We're just saying that, but let's tell people what triage is, because not everybody we're nurses and we know what that means, but people, the family don't know.
Triage is a sorting process where we actually take a quick history, and then we determine who needs to be seen first. So the sickest person should get seen first. So that's basically what it is. It's sorting you according to priorities. And it's not based on...
I got her first.
I got her first. It's not based on I got her first. So basically, if someone comes in, walks through the door, it's very possible that they walking through the door will be seen before someone who arrived by ambulance, because we're communicating in the front and in the back as well. But that's what we do with triage. But then also, if you're walking through the door and you're not as serious as those that's coming by ambulance, unfortunately, you do have to wait a bit. So we're trying even harder to communicate that when there are delays.
Okay, and what about when people are coming and they've had a situation that quote unquote may not be what we consider an emergency? Or can you say, give us some guidelines or some criteria as what we consider emergencies, as opposed to when people come and it's something they really could have seen the primary care physician for, and especially when they're telling us, oh, this has been going on for a couple of days, or you know what I mean?
Okay, but what's going on here lately? The sore throat. I had a sore throat started a couple of days ago, but today is a little bit worse than it was yesterday. In actual fact, that sore throat could have been taken care of on that first day if you go to your GP. Or I'll also put a plug in for the urgent care center. You can actually take those type of minor, the sore throats, the earaches, to the urgent care center between 4 and midnight.
Right.
During the week, rather than come into the emergency room, which will get cluttered.
And so in terms of that, where would that person be so that we explain to people, in terms of triage, what that means? Because people, I really and truly do not think people understand this.
in terms of triage,
People wait.
that person would be given a level 4 usually, and that means that it could take at least an hour, maybe longer, for them to be seen by the doctor.
Yeah, for real. And, you know.
So people understand, because the chest pain that's come in, that's having a heart attack, is going to bump your sore throat.
And that is correct. The chest pain, the serious road traffic accidents, the acute, and I'm saying acute because that's a clinical term, but someone who's coming in struggling to breathe, which, when I would say struggling to breathe, in layman's term, they can't speak a word.
Right.
Or they can only get one word out. That's some serious shortness of breath. But if you're coming in and you're reasoning, you can talk to us in sentences, then you're not as serious as someone who can't get any breath in.
Right. Your lifeline. You know, they really can't breathe. So while you are saying, I've got a sore throat, somebody come in here clutching their chest and they may be having a heart attack, certainly we have to take care of them.
That is correct.
Even though, you know, you've been there an hour. If they walk in the door right now.
Mm-hmm.
Okay.
Yes.
Now, I want to leave emergency just because we don't want to just give everything to emergency. And we love you, emergency room nurses and doctors and staff.
Yes, we do.
You make sure I say it to everybody because I won't be in trouble if I don't.
Absolutely.
Okay, but now say for instance somebody is on the ward and they're ready to go home. Like in terms of when do we start discharge planning? When do we start letting people know that you know, you're going to be discharged?
Discharge planning starts on admission. From the time you're in and admitted to a ward, your physician will say, you have such and such diagnosis, I'm going to give you such and such treatment for 3 days, whatever else, and I'm setting your discharge date for Friday, June the 4th.
Okay, so let me ask you this. Do we have a time when people, what is discharge time? Is there a designated discharge time?
Yeah. The discharge time right now, and we're continuing to look at it, is 11 a.m. Ideally, we need people out by 11 a.m. so that we can get that bed prepared for the next person. So let me say it now. These beds are hot. Our occupancy rate is high. We're the only show in town. And I'm glad you started with emergency, because I need the person that's sitting in emergency, that already knows they're going to be admitted, that's waiting for a bed, to relate to the person who's in PACU, having had surgery, who needs to go back to the ward to recover, to the patient in ICU who no longer needs ICU and needs to go to a ward bed, to the patient in emergency who needs to go to ICU.
So we're really talking about bed flu.
Okay, we're talking about bed flu.
About bed flu, how the hospital flu is, and how.
So this is what I'm saying. Sometimes it might be nice. I need another day to relax before I go home and deal with my family.
You know, Norma, let me tell you what we're going to do. Because that's going to be a little hard question.
Yes.
Because I actually have some email questions about that. All right, family, it's 8:14 here on Magic Mornings with Beverley Howell. We are in our Health is Wealth Hour, which is sponsored exclusively by Bermuda Healthcare Services and Brown Darrow Clinic. All right, Ms. Norma Smith, Clinical Director for MedSurg, and Nurse Lynnette Bean, Clinical Director of Critical Care Services at BHB, are going to talk to us because when I interrupted and went to that, we were talking about the bed flu, and we need people to understand how important and how things get impacted.
Yeah.
Yes. All right.
I think it may help, Beverly, just to state the obvious first before we start. We are the only hospital. We are going to run full. The only emergency room in the whole island is on 7 Point Finger Road. And
that is correct.
That is something that when we visit other hospitals, they wonder how we deal with that. Because emergency rooms, for example, in the U.S. can close. Okay, we're full, go to the hospital down the street.
They can divert.
We do not have that luxury. So we can have a full emergency room and full wards.
Yes.
So you see that's the case. Meanwhile, someone's having a road traffic accident, almost use the terminology acronym there. Road traffic accident, and on the way in, ambulance to a full emergency room and not a ward for them to go to. So my point is that when we set discharge dates and times, it's not a luxury. People very quickly move out of hotels. We know that the discharge time for a hotel is 11 a.m. and whether we have to put our suitcases out in the hall and sit in the lobby, we get out of the room by 11 a.m. We don't expect to be a Hilton. These are sick people, these are patients, but as we set discharge dates and times, we need the public to know that it's because we need that bed for your relative, your fellow Bermudian resident or whoever who's either in the emergency room needing to come up to a bed, in the operating room having recovered from surgery needing to come up to a bed, or in the ICU needing to come out.
You know what? Let's do this real basic. Let's just talk about somebody who's coming in for surgery.
Okay.
Let's start with that first.
A direct admission?
Yeah, a direct admission.
Okay.
Or an ST.
Yeah. Same day admission.
I'm using these acronyms. Tell me, I like them, but we're going to correct ourselves because we really want you to understand this.
Yeah.
So somebody who's having it's a same day admission.
Yes.
Right, and we need people to understand that discharge planning has to happen. You got to be thinking about that before you even come into the hospital.
Absolutely.
Correct?
Absolutely.
And all the things that you are going to need.
Yeah.
So if somebody comes in for surgery today, so they show up at whatever their designated time is, they have that surgical procedure, and then they go up to the ward.
Right.
Now,
and we have to have had our planning so tight that we know, preferably the day before, what bed that patient is going to go into. And that's based on Beverley Howell, who's been discharged, leaving that bed before 11 a.m. so that we can prepare that bed for Johnny Doe, who's coming up, having had his surgery, having come in as the same day admission.
I'm just letting you know I'm coming in.
Okay, I knew you would appreciate that.
I'm not coming. But
Yes.
I understand what you're saying.
Yeah.
So, and we sometimes, like, so if somebody gets, they're done in PACU, the peri anesthesia post-operative care unit, if they're down there and they can't get up to the ward, what has happened? Why can't they get up to that ward?
Okay. There's not a bed available.
And it's not available because of what? Because discharge time is 11
The planned discharge has not left. They've either decided. Remember, the situation that is acceptable is that patient is not well enough to be discharged. We do not discharge people that are unwell.
Yes, and that's
okay. So if something's happened overnight and that patient cannot leave, that is their bed.
Right.
Okay. But if all is going well and the person has said, well, I can't leave now. I need to have my lunch, and I don't see why my daughter should leave her job and come and pick me up for 11, and she'll come at 4.
Right. My daughter doesn't get off until 5, and then she's got to go pick up her children, and then she's going to go have her supper, and then she's going to come at 8 o'clock to pick us up.
These are the things you hear in the evening.
Right.
Right. So that may seem reasonable to the person, and I understand that, but what we're trying to show you today is how that blocks things up. We've now got to look for another bed that doesn't exist for that patient to come out of the OR. Meanwhile, 2 patients have come into emergency probably too that need admission beds, so they sit down in our system with no bed. That's what we call them.
And then
patients
we have
without beds.
There's a bad road traffic accident, and we have to get somebody into ICU. And ICU needs to move up.
The only way ICU can take that patient is if we move out one to the ward. So there we've got 4 patients vying for this one bed, and that's something we have to live with if it's because of the patient's situation. But we shouldn't live with that because the person that is occupying that bed now really needn't be in it because they've been discharged.
They decide they can't go home for whatever reason because they haven't thought about planning their discharge on admission. So Norma, let's go back to that in terms of, so now we got 4 people needing this bed. So how do we fix that? Because I guess then we may have to now talk about the overflow a little bit. And what does that mean? And does people, because I think sometimes it seems like it appears to be a perception that people think the care in the overflow is not what they would get if they were in the ACW. So let's clear up that myth first and tell people why.
It's amusing for us as nurses because you've actually got probably a better nurse-to-patient ratio when you're in overflow. I'm not saying it's ideal. True.
But that's
correct. We absolutely
do have a better ratio. Plus, not even 2 years ago, that was the hospital. I think that's what
Yeah.
it blows my mind.
Yeah.
Really, for real.
Yeah, yeah.
So let's tell people why would we need to send them to the overflow and how they could help us. So we, if the overflow is there if we need it.
Yeah.
But we probably would not need it as much if people had the understanding that when they come into the hospital, that discharge planning already needs to be in your mind.
Absolutely.
Correct?
Absolutely.
And we actually open the overflow when we have a greater demand for beds than the beds that we actually have available. So when we have 90 acute care beds, and when those beds are full and there's a demand coming from PACU, emergency, and ICU, we have to go to what we call overflow, and we have 12 beds on Curtis Ward. That we call
Curtis
Ward. Well, it's not it's still Curtis Ward. So I have
Okay.
the old Curtis Ward. It's still named Curtis Ward. So it's 12 beds,
Okay.
and we can admit there, and it's a priority. We really examine who we put over there as well, because if you're scheduled to be going home, say in a day or two, we may come and ask and say to you, we're going to transfer you over to the overflow to make room for someone who actually needs that acute care bed coming from PACU, emergency, and ICU.
But we still need to let people know that their care is not being compromised
And
because
the
they're
care-
doing it. And in fact, like Norma just
The
said,
ratio-
the ratio is actually
The
better.
ratio is wonderful. It's 1 nurse to 4 patients. And in less than 21 months ago, that's how we were nursing.
Yeah.
The care is that everything that they would need is actually provided for them. And it does happen. We try not to.
Yeah.
We don't want to have to open the overflow, but if there's a need.
Remembering,
We
we've
do.
got that so that patients are safe and continue to get their care, but overflow is definitely a burden on the system, on the healthcare system, on our costs and everything. So ideally, overflow is not something that we just go to, okay, well, we're full. No, we need our aggressive discharge planning. We need our patients as our partners to realize that we just don't want to get rid of you so that we can relax. We need that bed now that you have finished with it and you are completely better. We need that bed now for people that are coming in sick. It's a dynamic case. If you see, the public sees all these road traffic accidents out in the street. Just think about it. If we're full, as that ambulance is coming in, what is our plan? How do we keep the machinery moving so that we can adequately look after everybody? Not only adequately, we want to exceptionally look after.
Well, we give exceptional
Yeah,
care.
exactly. So it's really something, and I think that I know that the community is reasonable. So I thank you for this opportunity to explain to them, because I think sometimes they think, oh, we're just pushing people
Yeah.
out. We're not, and we will never take
Never.
this commitment. We will never discharge someone before they are medically fit
Right.
for discharge.
And I'm going to say something right now, and that does not necessarily happen in the U.S.
Absolutely.
Okay,
Absolutely.
people need to know that, because I don't think they necessarily
Yep.
realize that no, if you're not well enough, that you're not getting discharged. But we need to tell people too. So the clinical manager or the assistant clinical manager could come to you on a daily basis and have the conversation with you, because we want to be proactive. We don't want to wait until the hospital's full. So if we need to move you, like that will be shared with you during the day.
Yep.
So, and especially if you're boarded to go home the next day. Or the next couple of days, right? So the clinical manager or the assistant clinical manager will then have that conversation with you. No, we need to know.
And there are daily rounds with the physician and at least one of those persons, either the clinical manager or the assistant unit manager. And very soon you'll see it, especially on the 3rd floor, your date of discharge is going to be up on the little whiteboard that's in your room as a reminder to you and your family that that's what we're aiming for.
Well, I would just like to say it affects the emergency room as well, because on average we admit about 9 patients a day through the emergency room. So if we can't, in a timely manner, move our admitted patients from the emergency room, and as the caller just indicated, we actually have a process that has to go through when the bed is cleared. It has to be clean. So it's going to be about an hour before the patient from emergency can move up. So if I've got 9 people in emergency waiting for beds, that person could have been waiting from midnight, they could have been waiting since 4 o'clock in the afternoon, to move, it actually impacts on the entire service, because that means that that's a bed that I can't use for the person coming through the door as well. So when people are complaining about an emergency, how long they had to wait, many times they're waiting because we can't physically get them through. And
Exactly.
we have people sometimes
Because
in the
there's somebody
hallway
on the floor
that's
not moving.
not moving.
Right, and consequently, that's why we sometimes need to move people to the overflow, especially if they're going to be going home within the next 40, well, I guess we could say up to 72
Yes.
hours
Yeah.
if they've been given that, because pretty much they're medically stable at that point. But we need to enforce, or reinforce that nobody goes home, they're never discharged if they're unwell.
That's correct.
That's correct.
All right, no.
You know, Bev, you mentioned something earlier about that's not the situation you see in the U.S. I can't remember exactly what you were talking about. Another thing.
Oh,
that
I'm talking about in terms of your
Right.
length of stay.
Right.
Because
But-
we have DRGs.
But that's what I'm going to
DRGs
bring
in the
up. I don't
States.
think we mentioned that.
And
But in the U.S., we have what's called DRGs,
Oh, yeah,
and
let's tell them what
and
that
if you
is.
have
That's
Di-
diagnostic
related groups. So if you come in the hospital and the doctor says, I need this patient in hospital for 4 days, and that's what the insurance pays for. And on day 5, if you're still there, that's coming
on
out
you.
of that's on you. We don't do anything like that. We're just asking the community to work with us and realize the reasons that we need patients to be discharged promptly on the day that they are fit for discharge.
But at 8:49, I can't believe our
I
time is
know.
almost
It's
up.
so
So
quick.
I guess what I'm gonna say. Well, first of all, let me say this in case we run out of time. You guys are gonna have to come back because
Yeah.
I'm sure we didn't cover everything.
We can bring the
needed to cover.
triumvirate
Yeah,
with
the
us.
triumvirate. That Loretta needs to be here. She's having a vacation at this time. How dare she? Anyway, having said that, ladies, thank you so much for coming. And yes, you're gonna have to come back because it's a lot more that we need to cover. But in the few minutes that we have left, what exactly would you like to share with the family regarding the ACW?
Well, I just want to make sure it's not missed by our talk about discharge, and that it is a focus as soon as you come in, that with that, we are focused on you getting the treatment that will enable you to return home. So we are focused on what's wrong with you. We need you to be focused on what's wrong with you and how the treatment can help. So I wanted you to know that we still give caring, compassionate care.
Yes.
That is our first and most responsibility. With that, we hope that you've been able to see that by not moving efficiently out of the bed when you no longer need it, how it impacts many areas and many of your fellow community, and how the person on the stretcher down in emergency waiting to come up, or the patient that's had an OR surgery waiting to come up, or the person from ICU waiting to come up, or the person in the waiting room that really needs an emergency bed that is occupied by the 8 people that they have to come up is impacted. So I hope we've been kind of clear about what our bed flow situation is, and I thank you for the opportunity to share that.
No, I thank you for coming. And yes, because we do give exceptional care, and I want to make it perfectly clear.
Yeah.
Nobody is being pushed out of the hospital,
No.
and you are medically cleared by the doctor, not by the nurse, by the
Yeah.
doctor. And it's a whole team of people. We have the
Yes.
medical social worker involved,
Yeah.
OT, PT, everybody
Yeah.
is involved, just like Harley and Cody, and dietary, laundry, everybody is involved. Environmental services, it's a collaborative effort.
I think I want to make sure that people know that this ACW, we love our patients. It sounds cliche, but we do. And the ACW was all about making things better for patients. When I look at the dialysis patients who aren't sitting on top of each other anymore, the oncology with the beautiful space there, when I look at the wards where we do have the privilege now of giving people the privacy that they deserve on those wards, I just wanted to know that that is our focus.
Excellent.
And to continue to run that efficiently, we need the community's help.
Right.
And for emergency, I just ask that when you do come, if you're going to be admitted through the emergency room, that you, as a patient or your family member, identify one person that the healthcare workers can liaise with. Ask that question, how long do you expect me to be admitted? So that you have it even from the emergency room. But if you're not being admitted, when you do come, we give you discharge instructions that you follow up with your GP. And if you are getting sick, don't leave it to the last minute. Go to your GP so that you don't need the emergency room for minor stuff, that we can be freed up to look after those true emergency.
And right, and also because if they go to the primary care physician with quote unquote the minor stuff, it may not have to become that serious stuff and
that
require
is correct.
your admission
Yes.
to the hospital. Which
Absolutely.
Is, you know. And I just want to thank my guest this morning, Nurse Norma Smith, the Clinical Director of Med-Surg, and the Clinical Director of Critical Care Service, Nurse Lynnette Bean. Thank you guys so much for getting up so early in the morning and coming and sharing with me.
Tell you one more great thing about the ACW.
Okay.
As directors, we get to be physically together,
Yes.
along with the evening night managers, and I think that's led to a synergy where we work together and across our programs and really, really do well, and that can only benefit patients. So
That's right, because
Yes.
we're out
I want to
there
thank my neighbor,
exceptional-
Lynnette
Yes.
Bean, for being
I
with me
just
today.
appreciate you guys. You guys have so much fun.
Yes.
I gotta say hi to all the other evening night managers,
Yes.
Maxine Herbert Watson, Shelley Jean Gibbons, who left me. She just been on vacation for 3 weeks. I'm just saying. And Allison Smith and Vivian, who's been on vacation. She needs to get herself back there too. And of course Naomi, who's always there
Yes.
for us. We appreciate you, Naomi. And Michelle Barnett. No, I'm gonna get in trouble. Right? Let's stop calling this. I'm just
Karen,
getting
Kathy,
in trouble.
Denise.
I
Sorry.
know, I'm sorry, I'm
April.
gonna get in trouble.
I'm just shutting up to April, Veronica, Jennifer, Shanae.
Yeah,
All
they-
critical
all
I'm
care.
part
just
of
letting you all
yeah.
know that Nurses Month is over. No, we love you, our nurses, and we love all our clinical managers and assistant clinical
Yes, we
managers,
do.
and we all work together to provide exceptional care. We just want to have healthy communities and a strong partnerships.
And
Yeah?
one more thing, just shout out to our boss. Morning, Judy.
Morning,
Oh
Judy.
yes, morning, Chief. Oh yeah, boy, we're gonna be in trouble. All right, but no, thanks. All joking aside, I will say, nursing is a fabulous profession, but we don't work in isolation. We have all kinds of people helping us, and there's a whole lot of doctors out there who listen in, and we appreciate.
And we
all
would not
of
get
them.
those discharges
And
without the allied
we-
health care
and
team.
we- I was
Getting
just
them up
gonna
and
say,
walking and
Right, for sure.
fit, yeah.
It's a collaborative effort, definitely, at BHB and partnership, and we definitely have to include MWI in all of this too, because we appreciate them, and we work in partnership with them, and whenever it's necessary. So we appreciate you, and thank you both for
Thank
all
you,
that
Bev.
you do for nursing and healthcare, and for leadership at BHB.